Excuse me, everyone. Good afternoon, everyone, and a really warm welcome to the Royal Society of Edinburgh, or RSE's Contested Rural Environment Series. My name is Professor Sarah Skerritt, and I'm Chief Exec here at the RSE, and I'm very excited to be chairing the session today, particularly given the calibre of the speakers and you, the audience, and also because I have a research background in rural issues, so I'm personally very interested in what's being debated today. As Scotland's National Academy, the RSE's mission is to make knowledge useful, and this series, which is running over 5 weeks, is addressing 5 key issues that impact rural communities and environments in Scotland. Each week, we've been speaking to 2 experts who discuss the issues and potential solutions around land use change and restoring nature, energy futures, tourism, housing and population retention, health and social care, heritage and regional identity. This series builds on the recent Islands Past, Present and Future events, which highlighted some of the themes we're taking forward through discussion. The events are available to watch live on the RSE YouTube channel every Thursday from 12 till 1 until next Thursday, the 3rd of April, with the recordings available to watch after each event. I'm now going to introduce via their biogs the 2 speakers and the summariser for today's focus on health and social care in rural Scotland. Firstly, Professor Sarah Curtis, a Fellow of the Royal Society of Edinburgh. Sarah specialises in geographies of health and healthcare, focusing on why places matter for health and the socio-geographical processes producing inequalities in physical and mental health over the life course. Sarah has held positions including Professor of Geography, Queen Mary University London, and Professor of Health and Risk, Durham University. After retiring in 2016, she continued with research in her current roles as Professor Emerita, Durham University, and Honorary Professor at the University of Edinburgh. Her recent activities as Fellow of the FRSE and Fellow of the British Academy also include collaborations on topics including health inequalities, mental health, well-being, and place. Professor John Gillies, also a Fellow of the FRSE, was born in North Uist and lives in the Scottish borders. John has worked as a doctor in Malawi and rural Scotland. Professor Gillies was chair of the Royal College of GPs in Scotland from 2010 to 2014, and then from 2015 to 2019 he was deputy director of the Scottish School of Primary Care. Professor Gillies co-directs the Compassion Initiative within the Global Health Academy in Edinburgh. He's an honorary professor of general practice at the University of Edinburgh. And our summariser, Professor Frank Rennie, was Professor of Sustainable Rural Development at the University of the Highlands and Islands and Head of Research at Lewes Castle College, UHI. A natural scientist, he tutored on the MSc in Sustainable Rural Development and the MSc Digital Pedagogy, as well as supervising research students. His main research interests continue to be in human ecology, online education, and the benefits of digital networking for rural development. He's been an advisor to several government bodies, is a fellow of 6 learned societies, and Professor Emeritus of Sustainable Rural Development, and has published around 40 books so far, this briefing tells me. So I look forward to more. I'm now going to open the floor firstly to Professor Sarah Curtis and then Professor John Gillies to set out their stall for 5 minutes each, and I'll be keeping an eye on the clock. So firstly, a warm welcome to you, Sarah. The floor is yours.
Thank you, and good morning, everybody. I must start by saying that I don't have direct experience of life in remote and island communities in Scotland, but my experience as a health geographer means that I understand how places matter for health. The issue of rural environments relating to health and social care is a topic of international concern. The World Health Organization work on rural health equity considers issues including monitoring health inequalities, accessibility and barriers to services, supporting healthcare sector planning and addressing inequities, primary health care, including the need to invest in the health workforce and digital health, integrated planning to address wider determinants of rural health, building capacity and awareness of the importance of tackling rural health inequities, and spearheading research on interventions. I'd like to make some comments based on a rapid review of literature relating especially to Scotland. Research monitoring geographical health inequalities in Scotland may give varying impressions depending on the measures used, the areas and time periods covered, for example, I noted 2 studies of geographical variations in mental health in Scotland. One by Levine and Leyland examined variation in suicide levels using mortality data on populations of Scottish postcode area sectors. They conclude that men in remote rural areas were at greater risk compared with those in urban areas. Perhaps in contrast, Halliday and colleagues examined patterns of anxiety and depression amongst more than 100,000 individuals using data from the Scottish Longitudinal Study on self-reported mental health and linked administrative data on whether they were prescribed anxiolytic or antidepressant medications. And they conclude that mental illness was less common amongst residents in more remote and rural areas, especially those on islands. And they found that this was partly explained by indicators showing more cohesive neighbourhood structures measured in terms of social fragmentation and social cohesion in rural areas. Research on access to healthcare often highlights issues of access in remote and island communities. For example, Maxwell and colleagues reported research on access to cancer diagnosis and treatment among more than 4,000 patients in Scotland, of whom about a quarter lived in rural areas. And among lung cancer patients, rural patients had a significantly increased odds of a diagnostic interval between diagnosis and treatment of more than 90 days, which may increase risks of a worse outcome. More positively, Smith and colleagues reported a study on the Western Isles of the Western Isles Sensory Centre. This was opened in 2011 to provide advice, assessment, referrals, and practical interventions to support independent living for people with sensory impairments. And this service impacted positively on self-confidence and sense of self-esteem and safety. Action to promote better access to care is discussed in research focused on primary healthcare orientated systems, the need to invest in the workforce and digital health. For example, Stephen Gibb considered recruitment to social care roles in remote and rural contexts. And he concludes that refreshed new messaging is probably needed to attract, employ, and nurture young people to the social care sector in remote and rural places. And this would help to enhance capacity for integrated care. There are also issues concerning provision of infrastructure that are needed to operate health systems. The Orkney Partnership states that the biggest cross-cutting challenges locally are digital connectivity, transport, housing, and fuel poverty. So to conclude,
We've received a message saying the recording has stopped, but if you carry on, I'm sure the recording will pick up again. So sorry for the interruption, Sarah.
Thank you. I think I spoke too long, so I'll just try in the last few seconds to conclude. And crucial issues to consider relating to health and healthcare in remote, rural and island parts of Scotland may include the need to continue monitoring different aspects of health inequalities and the complex wider determinants of health, ways to address varying access to services, investing in workforce and issues of recruitment, and how development of digital health may improve access to care. Thank you very much.
Thank you for your very clear outline there, Sarah, including a summary of points. And sorry for the interruption. I've been reassured that the recording is all fine on YouTube, so thank you. Professor Gillies, over to you for your opening 5 minutes, please. Thank you.
Thank you very much, Sarah. Thank you very much, Sarah, for for your talk, and Sarah for the introduction. So, Professor Curtis mentioned that fostering integrated planning to address wider determinants of rural health was a name of the World Health Organization work on fostering rural equity. I want to make 2 points in my 5 minutes. The first is that health in communities in rural and island areas is essentially intersectoral, so it requires intersectoral action. I think this is closely connected to the wider determinants of rural health. And my second point is that we need to listen to communities more, both in their delineation of the problems that they face in accessing health and social care and other areas, and in their exploration of innovative ways in which they can be addressed. I'll give an example of this, but we also need to look at how they can be better supported. On the first point, intersectoral action is defined as action that involves several sectors of society, action by health, education, housing, environment, and local government sectors to enhance community health. And I would add to that list action on transport as transport infrastructure and performance, particularly in islands, but in every rural area, affects every sector relevant to community health. Social care, home care, education, workforce recruitment and retention, and housing. And also the performance of the local and wider economies is very relevant, as these will determine local employment patterns and patterns of demographic change. You might be interested in the recent closure of a care home in Malig for 18 months due to difficulties in finding staff to look after the clients, with great inconvenience to elderly clients and their relatives. And I think Becky will put a link to that report on the website. So to move from intersectoral action to innovative solutions and opportunities in and for communities, I want to talk about an innovative community research project on community well-being that I was involved with in North Uist, called Adyar Sund, Attention on Well-being. And the vision and drive behind that was Mary Morrison, who lives in North Uist. This was under Cónaic Uist, the North Uist Historical Society, which is not just about history, and was funded by the Wellcome Trust through the British Science Association. Started around COVID time on the basis you should never waste a good crisis. And I think that links to the project, both the RSE March event, Islands Present last year, and our summary report on Guan and Nilen. It should be on the chat by Becky. So the project lasted for 2 years and was a collaboration between Cónaic, the North Uist community, and academic partners, Gordon Wells of Guan and Nilen and the Language Sciences Institute at UHI, and Jess Wood, a PhD student in Aberdeen. And the University of St Andrews also supported digital aspects of the work. So central to this study was a survey on what contributed, a survey of the community on what contributed to people's sense of well-being. Full details are in the links. Just a few key points. This was a crofting community, so it's unsurprising that the environment was deemed important and concerns raised. 92% thought the environment was important. And there were, in the free text, there were words like inaction on crofting, coastal erosion and flooding of the Machar, sea level rise, and the rise in goose populations. 92% also thought a sense of community was important, and there's some really good quotes to illustrate that. 72% thought the Gaelic language was important, and this was both Gaelic speakers and non-Gaelic speakers thought this was important. 50% thought spirituality was an important part of community resource. 44% thought Uist heritage was important, 50% Uist culture. And that included, as for Gaelic, people who did not grow up in Uist. And perhaps very significantly, there was concern, 69% about not being heard, 72% about not being consulted at regional and local and national levels. So we used community researchers to develop a kind of community of practice in this area. And what this was really was a kind of assets-based approach, which was promulgated by Sir Harry Burns, FRSE, when he was Chief Medical Officer. So my 2 points are, we must take a multi-sector approach to developing community health and well-being. And communities can be innovative. They know a lot about what contributes, these local assets, to their health and well-being, and they can generate many of these assets through volunteering, engagement, guided walks to historical sites, invitations to Gaelic cafes, etc. Communities need to be listened to, empowered, and supported. Thank you.
Thank you very much, both John and Sarah. We really appreciate your opening remarks. We have a couple of questions to start with, and then I know more will come flooding in as we have every week. One for each of you, in fact. So, Sarah, what are the obstacles to recruiting more younger workers to health and social care work in remoter areas?
Well, based on the paper by Gibb that I was referring to, the sort of issues that seem to be important for the way that posts are advertised relate to the fact that younger people may have less confidence about their ability to engage with responsible issues and quality of life for the people that they're working with. It may be that they may not quite understand the emotional aspects of working in social care. They may need an idea of how the healthcare system works. They may not understand it fully. So there are quite a lot of different aspects. There might be issues about whether they feel that they will belong in the kind of community where they will be working, and whether if they're going to be asked to work flexibly, as seemed to be the case in some of the adverts for the work, what does that mean? So just a bit more work to work out what actually appeals to young people if they're looking at the adverts for posts that are being made available in rural and island communities.
Thank you. John, do you want to add to that at all based on your experience and living and working in the islands as one example, but also in the Scottish borders, of course?
I think both the borders and the Highlands and Islands have a demography which is skewed more towards older people, and I think that's part of the problem. I fully agree with Sarah that the evidence suggests that we need to do more to engage with younger people in communities and find out what would be attractive to them. So I don't have any more to add than that.
Grand, thank you very much. A question for you, John. You mentioned community-based research, community-led research. A question here is, how do we encourage more and better community-based research in rural areas, particularly around health and well-being?
I suspect there are people online who know a great deal more about that than I do. But I think the model that we used in ADR soon, Focus on Wellbeing, was very much the community representatives and the academics engaging as partners and co-creating and co-designing the research, co-designing the questionnaire, and looking together at the results. So a kind of joint interpretation of the findings to ensure that that what's published and what goes out in the name of the research is actually fully reflects the view of the community. So the community is not just a substrate for the research, but is fully engaged in all the processes through the research, from research design through to publication and dissemination. So, and I think we were very fortunate with our colleagues from Aberdeen who were fully engaged with that. And I think it also meant too that colleagues in Aberdeen who are not from the islands started to understand some of the difficulties of doing research in the islands, like when the ferries don't sail. So you can't. So your day or two planned to spend in the island doesn't work out at all, or when the weather is too bad. So I think it's a process of a deeper engagement, I think, between communities and academic researchers that we kind of piloted here, and I think that will bear dividends for relevant and useful research in the future.
I was going to ask about the knock-on effects of taking a community-led or community-based approach and what that generates that's different, not only in terms of what we find out from people's experiences, but by investing in communities to carry out research, are we then going to develop a longer legacy of increased capacity to keep doing this sort of work?
I would hope so, Sarah. I would certainly hope so. I think it's important that research dissemination doesn't just take place in academic journals, which are read by other academics. So there has to be local dissemination and opportunities for discussion in the community. of the findings, and that's certainly happened, led by Komanyakri Ujtatu and individuals within it since the research. And we've also, I think, the Guan and Ilan website has got a link to the final webinar that we did, where we engaged with parliamentarians, our local MSP, Kate Forbes, Minister for Gaelic, and Deputy First Minister who spoke. So we were able, through the community, to use these links to disseminate findings and discuss them further, both within the community and more widely with our representatives. Because as we saw, one of the concerns of the community was that they didn't feel that they were being adequately engaged with and listened to and involved in decisions by local and national government. So yes, I think and would hope that that would generate interest in other people to become community-based researchers.
Yeah, yeah, which adds to the retention of people in rural areas issue as well, doesn't it? Sarah, do you want to comment on community-based research? John's mentioned academic journals for academics, particularly in this area of health and social care. Would you like to comment at all on that topic?
So I think the question is about how we assess community linkages and strengths of community care. Was that your question?
The original question was, how do we encourage more and better community-based research in rural areas around health and social care? And then we moved on to think about the positive benefits of it and the legacy of such a focus.
I think that there are many different ways of looking at health and social care in rural communities. And I think one of the challenges sometimes is that if we're using statistics to try to get at the issues, sometimes either they're rather small numbers, and that may mean that they're not entirely reliable. Plus, there might be some ethical issues about disclosing who's who. So perhaps we don't have such comprehensive information, but we must remember that it's very important to learn from more qualitative studies that understand people's lived experience of life in these communities. And I think John's put his finger on quite a lot of those issues very well. So we need to listen to the voices from those areas in various different ways. And I think that maybe it's partly to do with having a more interdisciplinary approach to this challenge.
I wasn't being at all disparaging or pejorative about academic research. I think what I'm describing is complementary to that. And as I say, it's a lot of it is qualitative work, and it's perhaps harder to capture, but it's still important. So both are important, I think.
Yes, definitely. They give different perspectives on the same issues sometimes. Yeah, that's very helpful. Thank you. We have a question here from Polly, which is a slight change in tack now. Do the speakers have any suggestions on how we can help ensure that healthcare providers have the training and support they need to work effectively in rural communities with unique challenges? Who would like to venture into this first? John, you look ready to speak.
Okay. Yeah, it's a really important issue, and the key thing is to give people who are training for roles in health and social care the opportunity to train in rural areas. That's the key thing. The World Health Organization published a really good report on this in 2021, I think, on ways of encouraging recruitment and retention. It was globally, but there seem to be two key things that come out of the evidence that I can remember. One is that people who grow up in rural areas are more likely to want to return to work in rural areas, and I think that's certainly true in medical and clinical fields. And the second thing is that if people have positive experience of being trained in a rural or island environment, and they enjoy the experience, they learn their trade, whether that's nursing, physiotherapy, social worker, or medicine, then they're more likely to come back. So I think one of the things that we've seen throughout the last 20 years has been a kind of drift towards urbanity and a move towards the cities. And I think we have to make sure that that's countered in areas like in organisations like NHS Education Scotland, to ensure that there are still opportunities for people to learn in these fields in rural areas. And to their credit, NHS Education Scotland have done that, and they've recently set up the resource for remote rural healthcare, I think, which is a virtual institution which is starting to function now. But it's really offering opportunities for high quality training. That's what's needed.
Thank you, John. Sarah, would you like to add to John's response?
No, I think that that John's put forward some good points, and as I mentioned earlier, when we were talking about this, I think it is perhaps useful to take a look at the National Rural Health Forum sources. They held a meeting, as it happens, yesterday, where they brought together a lot of participants, particularly from the voluntary sector, and they discussed the issues, particularly around mental health in rural areas and how to address that. And it was clear that there was a good opportunity then to share information and to build up capacity, not only in the professional, if you like, sectors, the NHS and state social services, but also in the voluntary sector, which plays a very important role.
Thank you very much. And maybe we could have the link to the National Rural Mental Health Forum put in the YouTube chat. That would be grand. Thank you. We have a question here from NHS Highland RD&I. In NHS Highland, we're about to start a feasibility study on using virtual reality or VR to deliver training to med students in remote and rural locations. So this might relate back to the points you've been making about attracting healthcare providers to rural areas. Would either of you like to comment on virtual reality to deliver training?
I don't have any direct experience of using VR for training, but I know it is, well, simulations used very widely in clinical education now, and I think virtual reality is a development of that. I suppose I think I don't know anything about this initiative. I think it's as Sarah's work shows, that place is really important in rural health and social care, and so long as it was not used as a substitute for actually placing students in rural areas, but was used as an enhancement for students based in rural areas, I think that would be fine. I think there's probably evidence that it's a useful new modality of learning, but I always think that there's nothing to beat really face-to-face contact for education. I think it does offer a depth and a breadth of experience that is hard to beat. So yes, I'm sure it'll be explored widely, and I expect it could offer an enhancement.
Mm-hmm. I suppose there's a need perhaps within virtual reality to capture the elements you've talked about of cancelled ferries and frustrations of travel, but also the very real aspect of how healthcare professionals are embedded in their communities, and that can have advantages and disadvantages. So the daily relations that happen as well outside the medical practice, if you like. Yeah. Sarah, do you want to add anything on virtual reality?
Well, yes, the first issue might be if we're going to talk about virtual systems to support people, is will they be constantly and reliably accessible? One of the things that seemed to come out of reports that I was reading suggest that there are issues about ensuring the reliability of digital systems in more remote areas. And I hope that everybody listening to us today isn't having trouble with connections, but it probably does need further consideration how much one can rely on the digital system given those limitations.
Thank you very much. And talking of access, we have a question here from Martin Allen. How do you measure accurately who is not getting access to health and social care? How do we know that? What does either of your work tell us on that? Thank you.
You want to start on that, Sarah? I think.
Well, just maybe to come back to the example that I mentioned as I was racing through my review. We do, for example, have data sets relating to people's use of medical care. And that under very controlled conditions can be made available for research and can show us, for example, how long people are waiting for treatment when they're if they're diagnosed with a health problem. So there are digital or statistical data which one can draw on for quite large populations, including in rural areas, and they would be for people who have the right training and permissions can be made accessible. The Administrative Data Research Centre, for example, is a hub for this kind of work. So it's possible. It can be rather complicated, but it's not impossible.
Thank you. John, do you want to add to that at all?
Yeah, I think it's a really important question, and access to health and social care is it's more complicated than it used to be because, of course, a lot of access now is not face to face, but is online or via e-consult or on the phone. So I think there's quite a lot of complexity in the data on this. I think there is some evidence that sometimes the people who access health, certainly healthcare, best are those well-motivated middle-class people who know how to access things readily. And it's sometimes more difficult, particularly in a system which has become very busy and perhaps an overload, where you have to go into a queue for the phone. But it is a worry that sometimes people who do need healthcare miss out on it because they can't hang on the phone. Perhaps their phone runs out of minutes or whatever. So I think there are issues around that. And then there's a whole issue which I think we've touched on of digital access. You know, not everyone is able to has the digital skills to access healthcare, social care readily and without difficulty. So I think there's work to be done on that, both locally and, as Sarah says, with using national data. I wouldn't be confident we've cracked that one, really.
So we're talking about inequalities of access here. I wonder if that might lead us into another question around parity of esteem, and how can we ensure parity of esteem both between health and social care and then between physical and mental health, particularly in rural areas? Big question, but I think central around particularly some of the reforms that are being proposed or discussed.
Do you want to start on that one? Or?
Yes, I'm sorry, I didn't quite hear what the question was. It was parity
about how to ensure parity of esteem between health and social care and then between mental and physical health when we're considering rural areas.
Yes. Well, there are a lot of studies, of course, of both variations in health and variations in service use. The sort of data sets I mentioned earlier, which are for very large samples of the population, do allow us to look at what evidence there is that people have health problems, which may include their own self-reported health. We collect this kind of data, for example, in the census and so on, and whether those people are actually using services. So it might be possible to do large-scale studies more often on these topics, especially if support can be given to people who are aiming to do that kind of research, and also are able to gain access to the data through the appropriate routes.
Thank you. John, on parity of esteem.
Parity of esteem, another really important area. I think it is interesting how through the years of austerity and through to the present day that spending is UK and Scottish government spending on healthcare was protected, whereas spending on local authority care, which encompasses social care, was not protected. So, and I think that's an indication, perhaps, of where we are just now with parity of esteem. We now, of course, have health and social care partnerships, 31 or 32 of them throughout Scotland. And I suppose that is a way of trying to address that issue of parity of esteem in a structural way. But the fact that, say, we've just had to take some really emergency steps to bolster the care of mental health care for children and adolescents in Scotland, which had become virtually unobtainable because of the waiting lists, is an example of how we still have quite a long way to go in thinking about the importance of mental health. There's also, of course, recruitment difficulties for mental health professionals now in urban as well as rural areas throughout Scotland, psychiatrists and community mental health nurses. So I think the problem is partly structural. I think training again is really important, offering opportunities for high quality training for social work and healthcare professionals throughout Scotland, because there are many vacant posts, of course, throughout across the patch. I think one of the things we might come on to later is in Scotland. So just to broaden out the question a bit, Sarah, if I may,
of course,
we have a very centralised system of government. We have a UK government and we have a Scottish government based in Edinburgh. And if we compare our system to perhaps Scandinavian countries, power and fundraising is much more locally devolved in places like Finland and Norway and Denmark. And I've gradually come around to the conclusion that we are too centralised in Scotland, and then we can address better a lot of these problems where you need local prioritisation to address recruitment issues, transport infrastructure, housing, and so on, by giving more power to local authorities and to communities. So I think there's now a rule. I think the RSE has been asked to consult on a national rural plan, in fact, for Scotland. I think that's one of the things that came out quite strongly from the group I was on. So I think part of the problem, part of the issue addressing that, both in health and social care and in physical and mental health, is to have more local agency, because I think if you empower local government and local communities better, they will start to address these problems, perhaps in a more nuanced and innovative way than is sometimes possible through national plans.
Thank you. There's a question that builds exactly on what you're saying, actually, John, from Kate, about the resource that sits within communities. Kate says in rural areas, people often have close-knit community ties. Do the speakers have any ideas on how health and social care services could leverage these close relationships to improve care and support? So I suppose that builds a bit, but interrogates that a little bit more. John, I don't know if you want to continue, and then I can bring Sarah in on that.
Yes, I think it's a really good question. I mean, my experience as being a rural GP for 30 years in rural Scotland is that very often these close-knit community ties of family and community relationships are often very, very effective in providing care for people in their own homes in informal ways. So I'm sure it's a good idea to try and build on them, but I think these care and support through informal caring, I think, is often better in rural areas than it is in urban areas, often because families are close together, but often because communities are. I think Sarah mentioned that one of the reasons why there might be less anxiety and depression in rural areas was because of the cohesive nature of rural communities supporting people who had difficulties. So I don't know of any particular research on this, but I think I'd be a bit worried about a national initiative to do this. I think, again, very often communities know what needs to be done in their areas and needs to be supported to do it. I think sometimes at higher levels, people don't actually fully realize how much families and communities support vulnerable people, not just elderly people, but people with disabilities within their community. It's so, yeah, important issue and worth more exploration.
I suppose there's always that tension, isn't there, between a national initiative and local bottom-up generation of those initiatives. Maybe tension is an unkind word, but dimensions, those dimensions. Sarah, do you want to come in on this about making the most of close relationships in rural communities to improve care and support?
Well, I don't think I can't add much to what John's already said. I think he's expressed that very well. But we do have examples of ways that we can set up facilities and opportunities for local communities to help themselves. In relation to the issue about suicide rates among men, for example, the Men's Shed initiative is one which is quite often referred to and seems to be quite successful, just because they demonstrate how, in fact, men are quite inclined to try and do something about the challenges they're faced with. It's just that they don't always have the right setting and opportunity to do so. And if they are able to come together with other men who are similarly struggling with similar issues, then it helps them to start to make progress themselves, but also to help each other. So there are certainly good examples of this, and I think that of course, the challenges are for the kind of informal and voluntary organisations that help to provide the platforms and the opportunities and the support. Funding is often an issue, and it's difficult to plan long term. And of course, there's an ongoing discussion in Scotland about whether social and healthcare should be integrated or not. So perhaps there do need to be some decisions at a high level about resources and the way that services are organised. But I think John's making the point that in terms of how you actually implement that on the ground, local action is very important.
Thank you very much. Continuing the theme of place, we have a question from Martin Allen. So a geographical area can be ring fenced, and farmer consumption, for example, can be connected to patient support. So is there an argument here for ring fencing of geographical areas and the support within them?
Yes, I'm not quite sure that I've understood what's meant by ring fence, but certainly it may be possible, based on locally based knowledge, to identify the parts of local communities which need help most, and to focus attention there. As I mentioned when I was speaking at the beginning, there are some also some very sort of universal indicators of where one might look to identify areas where care might be usefully built up on the basis of community action.
Mm-hmm. John, do you want to add to that from a
So,
research or practitioner perspective?
I think that there are attempts being made, I think post the new GP contract in 2018, to provide better local data to help support decision making at a practice and a community level through the LIST initiative, which allocates a data analyst to local areas, I think within health and social care partnerships. I'm not sure what the evidence is for how well that data is being used. I think these changes happened just before COVID, of course, and I think we're still in this post-COVID recovery phase where we're trying to adapt to some of the very difficult health consequences of COVID, but to re-establish systems which existed before. I mean, in principle, yes, we ought to be using all the data we have to help focus care and resources where they're most needed. The Deep End project, which focuses on the 100 most deprived areas, deprived practices in Scotland, I think is a good example of that. They've collected huge amounts of data. I think that's often very helpful, both in drawing attention to the issues, but also in delivering and allocating resource to a degree anyway. So yes, good as a general principle, and I think the system of data analysts, I think, has a lot to offer at a local level, but needs further development.
Thank you. We've reached the time when I now ask Professor Frank Rennie to give some reflections for a few minutes on the discussion we've had, the interesting questions that have been received, and the responses from our two panelists. So I'd like to hand over to Frank now for a few minutes of reflection. Thank you, Frank.
Okay, thanks, Sarah. Again, that was a very comprehensive and extensive discussion there taking part. I have a whole page of notes there, and sometimes it loops round back to the same set of issues and whatnot. So forgive me if I repeat myself, and sometimes. General consensus, though, that health is more than the absence of disease. There was a point made, the need for continuous monitoring of health and services in rural areas, the importance of social cohesion for health, and also access issues. Access is more than just the physical access, because it's linked to other things like transport problems or fuel poverty, for example, within that. There's an issue there about how that exacerbates or modifies inequalities within the system. So therefore, we're looking at a whole range of intersectoral approaches for different sections, not to think about these things in isolation, but to work together. That includes investing in the workforce and the need to actually retain and recruit young people. And there was a message about the required thinking about how we communicate with young people more urgently. I mean, a study I did several years ago, for example, said that most people within the health service in the Hebrides preferred to stay here, even if they weren't involved in their current job, because they were embedded within their community. So there's a whole lot of issues of local examples that were thrown up, which highlighted the sense of well-being, the need for self-confidence within the environment. Comparative esteem was mentioned, but also things that we don't necessarily normally think about in terms of actually physical or mental health. Sense of community, language, cultural heritage, the feeling that you've been heard, that when you speak, you've been listened to. Several points made about the advantages of local assets that can make a huge contribution within the system, not just in terms of the research, which is people may feel or they have been or not consulted, but also in terms of the co-design of the system as it comes through, but also requirement for a fuller engagement, a deeper engagement. Several points made about the need to actually, the power of local dissemination, the importance of local organizations in making these contacts, the effectiveness of local networks, for example. That ties in some cases to training requirements, not just for the professionals within the rural areas, but also within the communities and how they can respond to that. I'm reminded of research I was involved in Australia, where they actually trained health professionals in the importance of rural areas before they were then posted out to rural areas, because there's such a heavy imbalance towards urban areas within Australia. Issues there with digital structures, not just in education, but also in communication with consultations and so forth. And you might be surprised, I think. My experience is that sometimes rural areas are actually better than the cities for digital communication, but not always the case. Again, looking at things in a study I was involved in Cornwall, where people were trained that, but then when they went out to the rural areas, they didn't have those resources, those consultants, these books and so on within the areas. So a whole range of things there. I think the general summary was that places matter for health.
Mm-hmm.
The nature of the place is important itself, and these are not one size fits all. These are heavily nuanced in terms of different practices, and therefore we might actually need to actually move the issues into look at how we do these things within local government, within social care, within education as a whole, not just for the specifics of the health issue that is presented within the clinical context. So I think there was one point about men in rural areas being greater risk than their urban counterparts. But again, that was highlighted about the importance of networks and support and self-assessment. So I could look back several times within that, Sarah, but that's probably the highlights that go through.
That's really helpful, Frank, and a tough job as always to bring those threads together. And if I were to do a word cloud from what you've just said, I think local and place came through strongly. Also, this the reality of how things intersect, so we can't just talk of health and social care in isolation, but it connects to the points made by Sarah and John around housing and transport and availability of work and so on. So that intersectionality remains crucial. Just before we close, the speakers have been primed to give one takeaway point each for us all to take away and keep thinking about in the area of health and social care in rural Scotland. So I'd like to ask Sarah first to let me know what her takeaway point would be for all of us, please.
Thank you. This is a big challenge because a number of issues here that we've touched on, which are important, I think. So I suppose I'm understanding that although, of course, there are big issues about inequalities of health with poor health in large urban areas which are deprived, we should not, while we're trying to tackle those, ignore the challenges of population health in rural and remote areas. And we need to think about how we can do more to support local community action, voluntary sector agencies, workplaces, which we haven't talked about much directly, but can be another important way of providing health support, and the use of public spaces, for example, and maybe try to be innovative and cross-sectoral as we tackle some of the challenges that are still faced. Thank you very much for listening, everybody.
Thank you, Sarah, for those valuable additional points. John, you have almost the last word before I say thank you to everyone. What would you like to give as your single takeaway point from today's session?
I think in a few sentences, first of all, at both local and national UK and national Scottish and UK government, avoid silo thinking. Think in terms of integrated planning and think in an intersectoral way to design services for people, and also listen to, empower and engage with local communities. Thank you very much for listening.
Thank you, John. So again, intersections, local and places, and including multiple voices at local, regional and national levels. So I'd like to thank our speakers again, Sarah and John, and also Frank as our summariser. This session and all sessions, including up to next Thursday, are available on the RSE's YouTube channel. So please do go and listen to all of those, and you can like the videos too and pass them on to your friends and family so that we can all share in this learning on a weekly basis. So many thanks again, and it's goodbye.